Hi, everyone. It's great to be with you. My name's Elizabeth Boham, and I'm an educator with IFM. And for the next hour and 15 minutes or so, we're going to be talking about the comprehensive elimination diet and how you prescribe the comprehensive elimination diet. And I am so excited to talk about this because it is really the piece of that I do almost every day in my practice, or actually I do it every day in my practice. I am always prescribing either a comprehensive elimination diet or some partial elimination diet, or often prescribing them. And they can be so powerful. Elimination diets are a great way to do a food first approach where patients can see huge benefits. And everybody coming into AFMCP has a different background with different education, but and with a different amount of nutrition education. My undergraduate and graduate degree was in nutrition. I love using food as medicine. I'm a registered dietitian, and so it's exciting to see how powerful elimination diets can be. But what we know is that not everybody has the same amount of nutrition education. And medical schools are notoriously really not meeting the need for nutrition education. I think in 2015, only 71% of medical schools were not meeting that minimum 25 hours of recommended nutrition education. So it's no wonder a lot of physicians really don't have the tools to be able to use food as medicine. So we're going to really, in the next hour, 15 minutes, really talk about how we can use a food first approach and how powerful an elimination diet is, and how you can start using it in your practice Monday morning. Because I want you to be able to have other tools other than just your prescription pad, right? So when somebody comes in with heartburn, for example, what else can you do other than that PPI? What else can you do for that patient with asthma other than the inhaler? Or, if somebody's got eczema, what else can you do other than reaching for that steroid cream? We want everybody to have these tools in their toolkit so they can use food as medicine. IFM's done an amazing job putting together resources for you. So we're going to highlight a lot of those during this lecture, but then spend some time in the toolkit because you will be amazed at all of the great resources in there that you can use in your practice. And they're so helpful and will make your job easier. So performance objectives for this lecture are to understand the fundamentals and variations of an elimination diet, recognize why and when you use an elimination diet, be able to implement the elimination diet, evaluate certain problems that may come up and what you can do about them with your patients, and assess how the patient does with the elimination diet. That is key. And we really want you to be ready Monday morning to be able to be doing this in your practice. So first of all, we're going to be talking about what is an elimination diet, the fundamentals, the variations, why you would use it, which patients you'd use it for, when you would use it for your, when it's going to be the most helpful, how to implement it, what if, right? There's problems or practical solutions. What if these side effects occur with your patients? And then the most important part of the comprehensive elimination diet, and I'm going to start off saying this is the most important part, is the reintroduction. So how do you assess how your patient responded to the elimination diet? How do you reintroduce foods? And we're going to walk you through that really carefully today. Within the go-to-it model, right, this is part of the initiate, the I, right? So in the initiate part, we are either performing further assessment, referring to a nutrition professional, lifestyle educator, other healthcare provider, and initiating therapy. And so the comprehensive elimination diet is part of your I, initiate. During this lecture, I want you to think about how you're going to practically be able to initiate a comprehensive elimination diet in your practice. What does your practice look like? Who do you need to support you to be able to do that? Do you need to have resources in the community or bringing somebody into your practice so that you can more optimally and easily and efficiently be able to prescribe an elimination diet with your patients? So that's important to think about. So I'm just going to, put that out there. So for the next hour or so, you can be thinking about practically how do you actually do this with your patients? We'll talk about that a little bit more as we go through. In my practice, so I'm at the Ultra Wellness Center in Lenox, Massachusetts, and we have 5 or so nutritionists. So I'm very lucky to have that. Every patient that comes in to the Ultra Wellness Center and sees a physician is required to see a nutritionist. And even though I have a large background in nutrition, all of the initiation of the comprehensive elimination diet occurs when that patient is with the nutritionist. Of course, I put it out there with the patient. I say, this is what I'm recommending for you. But the practical pieces of it, that our nutritionists run with it and are really on the front lines with our patients. And that's how our practice works. And so you want to just think about how is it going to work within your practice. So when you are initiating therapeutic interventions, you are working to reduce triggers and triggering events. And we're really wanting to talk about how you can do a food-first approach. And one of the things that the comprehensive elimination diet does is it reduces triggers. It is removing common inflammatory foods for your patient. And that is why many times patients feel so much better after they initiate a comprehensive elimination diet, because you're removing triggers. Of course, when you're deciding what to initiate with your patient, you're thinking about what are their symptoms like, how severe are their symptoms, how chronic are they, to help you decide, is the comprehensive elimination diet the tool that you're going to initiate first? In the 5R program, when you're removing, the removal of foods is part of that removing in the 5R program, right? That's where that comprehensive elimination diet fits in. Remember that when there is increased intestinal permeability, patients are going to respond and react to so many more foods than they were before they had increased intestinal permeability. So when a patient has increased intestinal permeability, they can start to react to foods that they never would have reacted to before. And so that's really the power of the comprehensive elimination diet. It's pulling away the inflammatory foods, and we often see that being necessary when somebody has increased intestinal permeability. We also know that foods in and of themselves can be triggers for increasing intestinal permeability. Foods can cause inflammation in the digestive system, and foods, especially gluten, can actually be the cause of that increased intestinal permeability, which then results in more and more food sensitivities. So just important to be paying attention to. You've seen this before, about the functional nutrition dietary interventions. And in AFMCP, we really focus on the core food plan, which you see up here on the top, and the first step interventions. So which include the cardiometabolic food plan and the comprehensive elimination diet. So if you're new to IFM, which most of you are, then really focus on these 3 food plans: the core food plan, the cardiometabolic food plan, and the elimination diet. So there are advanced therapeutic interventions. They are delved into more in the modules, and they may be effective for some of your patients. But if it seems overwhelming, and just focus on these 3, because you can get a lot of benefit and pretty much most of the benefit with these first 3 food plans. They're very effective, and it's fun to be able to implement them with your patients and then see how your patients respond with either the core food plan, cardiometabolic, or comprehensive elimination diet. As you know, there's so many different diets out there, and people are recommending, oh, try this, try this, try this. But these 3 basic ones will get you very, very far. Okay? So what? Let's start with the what. What are the fundamentals and variations of the elimination diet? Remember earlier today, you were learning about how people react to foods, right? So what an elimination diet is the removal of foods and food additives that can cause both an immunologic reaction and a non-immunologic reaction, okay? And I think this is really important to explain to patients. Sometimes patients get confused. Maybe they came in with IgE food allergy testing before and say, well, I didn't react to anything on that food panel. Why should I do an elimination diet? Or I'm not reactive in any way to this food. Why do you think this is causing me problems, right? So it's important to take the time to explain to them how many ways you can react to food. So you want to explain, like with dairy, for example, you can have an immunologic reaction to the protein in dairy, and it might be an immediate reaction, an IgE reaction, or it may be a delayed reaction, an IgG reaction. And in addition, it also could be a reaction to or an inability to digest the carbohydrate component of the dairy because you have a lactase deficiency. So there's so many ways you can react to a food. And it's important to recognize that and explain that sometimes to patients. The elimination diet is powerful. We know that there's no perfect test out there in terms of food allergies and food sensitivities. And there's false positives on testing, there's false negatives on testing. And so the power of the elimination diet is that you're just testing without, drawing blood or doing skin prick testing. You are evaluating how somebody's reacting to a food with just removing it and reintroducing it. Okay, so it can be really powerful, and you recognize the fact that a lot of testing is full of false positives and false negatives. So, and that's important to explain to patients as well. So IFM, as I said, has done a great job putting together these tools for you. This comprehensive elimination diet guide is in your toolkit. It's got a ton of information in it. It's great to share with patients. You might even choose to print some out so you can hand to patients or scribble on them, or you may have them available digitally, but they're really, really a helpful guide. So the comprehensive elimination diet, these are the highlights, right? It works to reduce inflammation, supports a healthy microbiome. It is gluten-free and dairy-free. It's rich in those phytonutrients that work to heal the gut. It works to lower toxic burden in the body. There is no caloric restriction on the comprehensive elimination diet. And that's important to sort of notice and pay attention to. It's really not intended to be for weight loss. Some people do lose weight on the comprehensive elimination diet, and sometimes that's something that somebody's working to achieve, and so that's okay. Notice that when patients lose, 10 pounds in a week or so, that is often, when they have that quick weight loss, that's often because they've removed an inflammatory food for them. So they've removed something that they were eating that was causing their body inflammation. And so they lost a lot of water weight as well. And so, if you lose 10 pounds in a week, it is not all fat weight loss, right? Most of that, or a good portion of that, is just the loss of water, okay? There are patients that you may choose to be doing a comprehensive elimination diet for that do not need to lose weight, or actually cannot lose weight. Like they are on the lower end of their weight already, maybe even underweight, and you really don't want them to lose weight. And so it's important to pay attention to all of the, healthy fats that are allowed in the comprehensive elimination diet, and giving them a lot of good food choices so that they don't lose weight. So the intention of the comprehensive elimination diet is not necessarily weight loss. It is to sort of get a sense of what foods are causing your body inflammation. So it promotes body awareness to foods. It can identify food triggers, and it works to lower inflammation. So here are all the components of that comprehensive elimination diet. So this last one here promotes body awareness to food. And for some of your patients, that is a wonderful thing, right? Many of your patients need more awareness a body awareness and how is this food impacting my body. But so you have some patients who have a lot of body awareness and actually may need less body awareness. And so it's really important that you take the time to get to know your patient, gather that information, gather their story before you make the decision if a comprehensive elimination diet is right for them. So, you want to make sure that patient is educated, that they know why you're doing this and what you're looking for. You're looking to see if foods are contributing to their symptoms. You want to really give them some stories or research to help them feel confident that this is a good way to move forward. And you want a really straightforward, practical, easy program to follow, which is what we've put together with IFM. When you're gathering that information on your patient, you're thinking about people who would not be the right choice for a comprehensive elimination diet, right? So maybe a patient with a past history of anaphylaxis, people who are highly allergic or brittle asthmatic, removing foods and reintroducing them in this way is not necessarily safe. They could have a real significant reaction to a food. And so you want to be really careful. And you're not necessarily doing this to reintroduce an IgE or a suspected IgE reaction to a food. So be careful with those patients. It's really not intended for pregnant women. There are times you may need to do a partial elimination diet with a pregnant woman, but the comprehensive elimination diet is not my first choice for my pregnant women. They need to be eating more calories and not necessarily restricting and on a really good, healthy food plan. And the immune system is shifted during pregnancy as well, so it's not really the best time to kind of do everything that you're trying to identify within the comprehensive elimination diet. And of course, your patients with eating disorders. This is critical. Anorexia or orthorexia, right? Orthorexia is that preoccupation with eating foods that are believed to be healthy, that patient believes to be healthy, or that preoccupation with eating healthy foods and the preoccupation with avoiding foods that may be causing their body symptoms, or the obsessive removal of foods that may be causing their body symptoms. We've all seen this with our patients. We know it's common. We sometimes will attract patients within our practice because functional medicine understands the connection with food and symptoms. Sometimes we end up attracting more patients that may be really preoccupied with this connection. Knowing that and knowing the concerns around eating disorders, orthorexia, anorexia, it's really important that we screen our patients really carefully. And if we're getting any red flags, we really change the way we're having that conversation around food and symptoms. You back off with recommending a comprehensive elimination diet, and you just really maybe speak to a healthy food plan. And that's really important. We don't want to be feeding into orthorexia or anorexia or some disordered eating. That's very important. Okay. Whenever possible, the goal of the comprehensive elimination diet, right, is really a healthy food plan. And when that person, if they identify a bunch of foods that are causing their body symptoms, we're working to heal the digestive system. We're doing that 5R approach to heal the digestive system so we can add back in healthy foods. I've had multiple times where people will come to me, they've had food sensitivity testing that showed an IgG reaction to celery or blueberries or broccoli, right? And they stayed off of that food for years and years and years because of that test that they did in the past. It's really important that we work to reintroduce these foods and see how that patient reacts, because you want them to be on a really good, healthy food plan that's as variable as possible and not restrictive. One of the things I wanted to mention before you start a comprehensive elimination diet with your patient, if there's any question that they may have celiac, and you want to do the testing for celiac before starting the elimination diet, especially with your kids. If you're thinking you're going to be removing gluten and they're eating gluten at this time, get that celiac panel beforehand, so that you know where they where they stand at this time. Okay, why and when? Why are you doing the comprehensive elimination diet? You want to understand if there's a connection between foods and their symptoms. Are there allergies, sensitivities, intolerances? You want to clear the playing field. This can work to help support the body's detoxification system, and it can help transition your patient into a cleaner, healthier food plan in the long term. It's a great place to start. A lot of patients get hooked. Once they start feeling better, they get hooked and they want to eat healthier. And even if you're able to reintroduce some of the foods in the future, it's a way that you can transition them into a healthier food plan. As I was mentioning, there is a lot of false positives and false negatives within food allergy and food sensitivity testing. It's hard to manage food reactions because of the lack of uniformity in a lot of the testing and just how the level of false positives and false negative within the testing. And so again, I reiterate that with my patients, I explain that to my patients, but just recognize that there's no perfect test for either IgE food allergies or IgG or IgA food sensitivities or intolerances. The testing can be helpful, but it's not perfect. So combining the testing with a comprehensive elimination diet or just doing a comprehensive elimination diet is really powerful. So this was, this lecture earlier that you had heard, you've seen this before, an IgE food allergy is an immediate reaction to a food. Remember, that can occur every time that person eats the food. It can occur even if they eat a small amount of that food, and it is more immediate, and it is often more sustained, like lifelong of a reaction, typically. Food sensitivities or intolerances may take several hours to days to occur. They may not happen when somebody has a small exposure to that food, and it may be cumulative. It may be, these sensitivities and intolerances may be involving the immune system, like an IgG, IgA reaction, or it may be like a histamine intolerance or a lactase deficiency. So there's multiple ways you can react to a food, as I was speaking to earlier. And as I said, it can take days to build up in their system. I don't have celiac disease, but I do have some gluten intolerance. But every once in a while, you go, oh, is this really something I need to worry about? And so last week was my husband's birthday. And so there was some cake around, and there was also, he had made this delicious lentil vegetable soup that really, really went well with this sourdough whole grain type of a really hard bread. And so, I don't really eat any gluten these days, but I had a little bit of the bread, and then a few days later there was the birthday and a little bit of cake, and then all of a sudden I woke up and I felt like I was hit by a truck, and my joints were hurting and I was exhausted, and I was like, what is going on, right? And then I realized, I'm like, oh, this built up in my system again because I haven't really been eating any gluten. And then I just had it a few days in a row. And I think that is the reason that sometimes it's hard for people to identify food sensitivities or food intolerances because they're not immediate. And they might not be sometimes when you eat, I can get away with eating a little gluten here or there. But it's when I have it, 3 days in a row, then all of a sudden I'm like, okay, that's how I feel with this, right? That's very common for our patients and makes it really tricky for them sometimes to identify what food is causing their symptom. And that is why this methodical approach to the comprehensive elimination diet is so impactful. So, and again, and we're going to go through this today, not just the elimination, but the reintroduction. As I mentioned, there's other ways you can react to foods. You can react to foods because of how they're feeding the microbiome, which is fascinating. There's some research like here by Dr. Ebringer, and how, he just done a lot of research with ankylosing spondylitis. And when you do a low starch diet, the theory is that you are not feeding the microbes like Klebsiella that may be triggering this autoimmune reaction. So sometimes the removal of a food helps the symptom because of how it shifts the microbiome, which I think is really fascinating. Of course, certain foods may impact inflammation in the body. And of course, there's these gluteomorphins and caseomorphins. These are these components from gluten and dairy that can impact the opioid receptor. They can cross the blood-brain barrier and have an impact on focus, cognition, mood as well. So there's so many ways you can react to food. And it all does come back to this gut epithelium, right? That intestinal barrier. That's one cell layer that divides where the inside of the intestine with the inside of the body. And if that barrier is broken down because of inflammatory foods or certain medications, NSAIDs, not eating a good healthy diet, malnutrition, anorexia, celiac disease, food sensitivities, all of these things can result in us becoming more sensitive to more and more foods. And the goal of the elimination diet is to lower the inflammation that food is causing the body at this time. It's part of that 5R program, that remove, as I said. And the idea is that when the gut is healed, that many of these foods, especially the healthy ones, will be reintroduced into the diet. As Sid Baker said, his tack rule, if you're stepping on more than one tack, just eliminating one tack is not going to be enough to take the pain away. So that's important to remember, the tack rule, and why the elimination diet is so powerful. Sometimes when you do a comprehensive elimination diet, you're then removing multiple tacks, and you can see how much food is impacting that patient. And of course, sometimes the comprehensive elimination diet is not enough. I am often doing the comprehensive elimination diet when I'm waiting for testing to come back. It's often what I do at that first appointment, especially with my patients where there's so much going on and I'm overwhelmed and I'm not even sure where to begin. I often go toward that comprehensive elimination diet first and foremost, just to clear the playing field, to pull away a lot of tacks and to see how much that helps my patient improve while I'm getting the testing back. So it's that first thing that I often do. And then when testing comes back, I can then use, okay, how did you do on this elimination diet? And I've got these tests, and that can help me then know, do I need to do more? For example, if you're doing a comprehensive elimination diet and looking to see how much is that improving this patient's eczema or digestive system, and they get all better just with the dietary change, you've got your answer right there, right? But maybe they don't get all better. And then you're like, okay, I need to do further testing. Maybe there's some dysbiosis that needs to be treated, or a nutritional deficiency, for example. So when do you do that comprehensive elimination diet? So, this is a good handout or sheet for you to have. You can print this out or just, take a screenshot and have it, so you can remember when you're going to be doing it. I often reach to that comprehensive elimination diet with patients with a lot of gut issues, joint pain, muscle aches. Maybe they've got autoimmune disease, fatigue, asthma, atopy, myalgias and arthralgias, depression. Common ATMs, right, would be antecedents, triggers, and mediators. Lots of infections, gut infections, antibiotics. Patients will always often say, well, I was doing fine. I didn't react to this food until I then had this gut infection, for example. Trauma, stress. Maybe their mother had group B strep and needed antibiotics during labor and childbirth. Lots of acid blocker medication. So all of these things. Of course, if you've got your patient with a GERD or EOE or irritable bowel, these are times where you may be reaching for that comprehensive elimination diet. Just to note, there are a lot of conventional organizations out there recommending elimination diets, and we should recognize that there's a lot of research and science behind these. For example, the American Urological Guidelines for interstitial cystitis talk about the power of the elimination diet. Or the American College of Gastroenterology with IBS talk about the power of lower FODMAP foods or a gluten-free diet. The National Institute for Allergy and Infectious Disease, mentions that we need to look beyond IgE-mediated food allergies when we're dealing with certain symptoms. Or for EOE, we're going to talk a little bit more about that. Or, of course, inflammatory bowel disease and removal of dairy. There's a lot of references here as well as in the addendum for you to reference and share with your patients if you need to. How? Well, I want you to be able to implement this elimination diet. So how do we do it? So, there's a spectrum of types of eliminations where on your left-hand side, you've got your single food elimination. Then you could do maybe a gluten dairy-free elimination or a modified elimination, which would include things like the 6-food elimination diet or the low FODMAPs diet. Then you'll see here the comprehensive elimination diet, which is more comprehensive than those others. And then there's even a low antigenic diet, right? That's even, removes more foods. And of course, there's fasting, which is a definite elimination. So how do you decide? How do you decide with your patients where you're going to start? Well, in general, for me and, clinically, I'm always thinking about, okay, what's their age? Are we talking about a child here? Somebody who, you need to be a little bit more careful with the amount of calories and you don't want to overly restrict. So I might do a partial elimination diet or a 1-food or 2-food elimination diet with my younger kids. And it also depends on what their symptoms are like. How symptomatic are they? How motivated are they to change? What else have they tried in the past? So willingness and level of illness will impact when you choose to do the comprehensive elimination diet, as you could imagine. Okay, so here's a bunch of the different diets that we were just showing you on the other slide. So I just want to speak to a few of these just to highlight them. So we talked about the 6-food elimination diet. There's some really interesting, good research here on the 6-food elimination diet and EOE, or eosinophilic esophagitis. And with what they've shown, what this study's shown and others have as well, is by removal of these 6 foods, which include the removal of milk, egg, wheat, soy, peanut, tree nut, and seafood, resulted in improvement in the patient's symptoms, as well as improvement and lowering of the amount of eosinophils on biopsy, which is pretty amazing. What's so interesting, I think, with this research is that, allergy testing did not give them any guidance as to how the patients would improve from symptoms or when they looked at their pathology. So, meaning that it wasn't like not every patient needed to remove and continue to remove all 6 of these foods. And they didn't show the foods that they were really reacting to or that caused more eosinophils when they on biopsy were not necessarily the foods that caused more IgE reaction on blood tests. So that there was no concordance with prior food allergy testing and the patient's symptoms or how they improved in terms of their level of eosinophils. The other thing that this study showed, and others have as well, is that this is something, that can result in long-term reduction in eosinophils and symptoms. And so this is something, it's a real possible drug-free maintenance therapy that we can use with our patients with EOE. Of course, there's the FODMAPs diet, the low FODMAPs diet, where many of you know about this, right? So FODMAPs are the fermentable oligosaccharides, disaccharides, monosaccharides, and polys. And they're these short-chain carbohydrates that are poorly absorbed. They're more poorly absorbed when there is a low absorptive capacity in the small intestine, when there is a quick transit time, or when there is a small bowel overgrowth like SIBO. And so what can happen in these situations is these poorly absorbed carbohydrates can get fermented in the large intestine, lots of gases produce, water gets pulled into the bowel, you get bloating, changes in bowel movements, diarrhea, constipation. And so the low FODMAPs diet can be really effective, especially for people with irritable bowel syndrome, and especially the patients that have SIBO. Not all of these high FODMAP foods we don't want to remove them all forever, and not for some of them you may choose to remove forever, but for other ones you want to reintroduce over time. This is really spoken about more in the GI module. We really delve into it there, but these are just some of those high FODMAP foods that are removed or lowered on a low FODMAPs diet. And as you know, there's a lot of tools in your toolkit that are really helpful that you can start to pay attention to and look into if you want to be using this for your patients. So let's really get into that comprehensive elimination diet. So when you're doing a comprehensive elimination diet, you want to be paying attention to both the foods to avoid as well as the foods to eat. And that's really important. You want your patients to feel confident that they have a lot of foods that they can eat and choose from, okay? So the foods to eat here, you'll see the dairy alternatives, fish, certain fruits, certain gluten-free grains, right? You want to really give them an idea, okay, you want to focus on the foods to eat. I think that's important so people aren't feeling deprived and they have alternatives. You want a protocol that's flexible and adaptable, it's straightforward, and it's designed to allow for consistent evaluation and modification for your patient. And that's really what IFM has put together. And feel free to adapt this elimination diet for your patient and for what you think is going on and what they may benefit from. So here in this comprehensive guide, just so you know, there's the food substitutes to give your patients ideas of what they can eat instead, how to get started, which is really important, some just certain helpful hints, why you want to increase anti-inflammatory foods and how to incorporate them into your diet. And then, as I keep coming back to the importance of the reintroduction of your foods, and we're gonna delve into that a little later. It's important here to just re-emphasize that patients do better when they have a clinician that's working with them. So the intensive dietary education is really important for a patient to have success. It's really important for patients to have access to somebody to ask questions, to check in with, how am I doing? How am I responding? This really helps your patient be more successful. So, who's the nutritionist you have on board that's going to help your patients be successful? How long do you do an elimination diet? It's typically at least 3 weeks. And the reason behind this is because of the half-life of the IgG immunoglobulin. So IgG immunoglobulins make up about 75% of all of our immunoglobulins and are an important aspect of food sensitivities. So, the half-life is 21 to 23 days. So that's why 3 weeks is often chosen, because by 3 weeks, you're going to have cut back the amount of those IgGs against a certain food by at least a half. And there are times where I will do longer. So, for example, if somebody has an issue like eczema with their skin or acne, I often will say to them, let's give this 6 weeks, because skin takes 6 weeks to turn over. So, you may start to see decreases in inflammation in the eczema within those 3 weeks, but you may not see as much healing as you would if you let it go for a full 6 weeks. So you can, by all means, go beyond 3 weeks, but you want to really encourage your patient for those first 3 weeks to be as in as possible. Really, give it the good college try, because that's where you're going to get a ton of information. And again, you're going to focus on the foods that they can eat. This is the Elimination Diet Food Plan that's in your toolkit. And what you'll notice here, you'll notice the red, the green, and the purple circles, squares, and triangles, just to highlight to you and your patient if you need to remove histamine foods, for example. You're gonna avoid the foods that have the red circle next to them. Or let's say you're gonna also do a low nightshade diet. That's gonna help you do that within this plan. So, as I said, this is a real great resource, and you want to, have it for your patients to review so they can learn about why they're doing what they're doing. Okay, so what do we remove from a comprehensive elimination diet? So in general, we're removing the foods that are eaten often many times during a day. We're removing foods that are more common to cause food sensitivities and food allergies in patients. And we're working to remove toxins from the diet. So the comprehensive elimination diet works to remove all of those things. We remove gluten-containing grains on the comprehensive elimination diet. The reason behind that is the proteins in gluten, the gliadins, have been shown to break down the microvilli, right? Those villi in your intestines. They definitely do that with patients with celiac disease, but they have been shown to cause increased intestinal permeability in others. Possibly it's a common food sensitivity, allergy, and intolerance. It is associated with a lot of gut issues and autoimmune disease. And in addition, a lot of our gluten-containing grains are treated with pesticides and herbicides like glyphosate that cause damage to the gut and can cause inflammation. So a comprehensive elimination diet is a gluten-free diet. It is also corn-free. Corn is, in a ton of processed foods. So removing corn helps remove a lot of processed foods. A lot of our corn also is genetically modified. And so it is something that is removed during the comprehensive elimination diet, as is soy. Soy is very similarly in a lot of processed food and is often genetically modified and is removed during the 3-week comprehensive elimination diet. Beef and pork, they are a part of a lot of processed food as well as fast foods. And in addition, beef and pork are also, if they're conventionally grown or conventional sources of beef and pork, they can have a lot of toxins in them as well as antibiotics that you're going to work to remove. Dairy is probably the most common food that people react to, I'd say. The most common food reaction that we see, whether it's a food allergy, as I said earlier, a food intolerance, like a lactase deficiency, or a sensitivity, a delayed reaction to dairy. There are so many reasons that you can react to dairy. So it is removed in the comprehensive elimination diet. Even, somewhere between 25 and 90% of the world's population have a deficiency of lactase. And as we get older, that percentage increases. So we see more and more patients. Patients that have issues, they've had gut infections, can have problems with lactose as well. So it's something we're seeing a lot of. In addition, a lot of milk has hormones or antibiotics introduced into it that we want to avoid. Eggs are removed off of the comprehensive elimination diet. Eggs are a common allergen. There are times, though, because of the nutrition potential of eggs, that this is one of the first foods I may reintroduce with some patients, depending on their story. And of course, we're removing sugar. As you know, sugar and high sugar foods are really inflammatory to the body and to the gut, and our diet has way too much sugar in it. So in addition, you're removing the common allergen foods and inflammatory foods and really focusing on anti-inflammatory foods, but you may also choose to remove sugar foods further, or carbohydrates further, is what I meant to say. You may be also doing more of a lower histamine or a lower nightshade diet. You can modify this and become more restrictive if needed with certain patients. So what do you eat? You can eat vegetables. You can have vegetables, vegetables, vegetables. Now, there are some patients, though, where we do think about the nightshades. And so the nightshade vegetables are potatoes, eggplant, peppers, tomatoes, cayenne, and chili pepper. And, so for some patients, they may be reacting to nightshades. Nightshades are interesting. There are a lot of good phytonutrients in these nightshade vegetables. And so we don't always want to remove them if we don't have to. But if a patient's not getting better as much as you want them to improve, or if you see certain symptoms, for example, joint pain or itching scars, there is some interesting connections. We definitely see some connections when people remove these nightshade vegetables. They see an improvement or less, they have less itching of those itchy scars, or they see less joint pain or stiffness. Now, this is not across the board. This is just with some patients. So you may choose to do a nightshade-free diet with some patients. Of course, you want to reintroduce them so that you're not removing a food forever that might be a healthy food and a good portion for their diet and for their health. Fruits, most fruits are really allowed on the comprehensive elimination diet. Really, you want to avoid a lot of juices, and if somebody has some insulin resistance, metabolic syndrome, or they're at risk for overgrowth of yeast or candida, you may be watching the amount of fruit they're getting into their diet. This is a great tool in your toolkit. It talks about, maybe does your patient have an issue with yeast or candida in their body, and maybe you want to avoid sugars or fruits even further. And, what we know is, maybe the research on the connection with a low fruit diet and candida is lacking. We need a little more research there, but definitely we see this with a lot of our patients. They will tell us, they will notice. For those patients who are prone to yeast overgrowth, they will notice that if they consume too much fruit, they may have more vaginal yeast or more bloating or more thrush. And we do see that with our patients, and they need to be a little bit more restricted there. With the grains, really rice is fine on the comprehensive elimination diet, and all types of rice. Again, you may be watching this if somebody has some metabolic syndrome, and you just need to watch the amount. There's other grains too to include and to think about and highlight for your patients because they're so rich in nutritions, like quinoa and millet and buckwheat. Remember, buckwheat, even though it sounds like it, is not a wheat, it's a seed, and so it can be used on a comprehensive elimination diet. Protein, fish, poultry, lamb, nuts, or pine nuts, beans, except soy. On the 6-food elimination diet, remember that there's no fish or tree nuts, and some clinicians may be backing off on beans and lentils because of the lectins. So let's talk about lectins for a minute. Like, does everybody need to be on a lower lectin diet? Is it helpful? It's important to recognize that that these lectins, these components of a lot of our plant food, may have an impact on some people's health. But there's also a lot of benefits of lectins. Plant lectins have a lot of antimicrobial activity in them. We also know that plant lectins, when we cook or soak our beans and our grains, the lectin content decreases. When we pressure cook, sprout, or ferment them, it also decreases. And so the lectin content will shift depending on how that food is prepared. So it's not something that I'm always pulling away when I'm doing a comprehensive elimination diet, but there are times where, depending on the situation, we may lower lectins a little bit further. Histamine. I'm thinking about histamine and histamine foods when I've got a patient with like migraine headaches or urticaria, itchy skin, congestion, issues with mast cell issues. Histamine intolerance is about 1% of the population, so it's quite common. It is definitely impacted by your genetics. Some people don't have a variation in their DAO, their gene that impacts the DAO enzyme, and as a result, they are more prone to histamine intolerance. So there is a genetic connection. We also know that certain medications can make somebody histamine intolerant while they're on those medications. So there can be shifts in how well you tolerate histamine based on which medication you're on, or if there's been damage to the gut. So if there's been damage to that gut epithelial layer because of infection or a food intolerance or another medication, that you can then become more histamine intolerant for a period of time. We do know that vitamin C and B6 can help support that DAO enzyme. And so by replacing these nutrients, that can help certain people be less histamine intolerant. And we sometimes will use a DAO enzyme with meals, and it can help some people with these symptoms. Of course, we're doing that 5R program to heal the gut so that they're not so reactive to foods, including the high histamine foods. Okay, so let's get started. When we're doing that comprehensive elimination diet, planning is key. Really work to help your patients think ahead and plan for doing this, because that's going to make them more successful. So at least 1 to 2 weeks before they embark on the comprehensive elimination diet, they want to be planning it. They want to be working to cut back on their caffeine intake. They want to make a shopping list and buy some important foods. See if they have, what kind of support system do they have? What's going to help them through this? Are they going to do it with somebody else, with a spouse or a friend? And would they benefit from a medical food just to support them? Have them think about cooking a little bit of extra things that they can snack on so that they don't go hungry or that they have enough calories for them. Cut back on their caffeine. If they're having 2 cups a day of coffee, have them cut back in half, like to 1 cup a day for 3 to 4 days, and then cut that in half again. Talk to them about how to read labels. Highlight that in the comprehensive guide. That's important for them to be paying attention to, especially if they're not yet on a real whole foods diet. This is a big shift for them. Talk about the importance of eating regularly and staying hydrated. Discuss with them the importance of having some good healthy snacks around. Leftover chicken, rice crackers, vegetables, and salsa. Having those foods with you so that your blood sugar doesn't drop. Having a good protein source at every meal so you feel satiated and you don't feel so hungry. So plan ahead, make snack foods, plan your meals. Of course, have fresh food whenever possible, but have some ways that you can grab something if you're feeling hungry at that moment. Talk to them about how they can eat out. Discuss common pitfalls. Where hidden foods. Where does some wheat or dairy show up in foods where you wouldn't suspect it? Some people mistakenly think an egg substitute is not egg, but it is actually an egg white. It is egg. It was really just developed to lower cholesterol. So it's not non-egg substance and should not be eaten on a comprehensive elimination diet. A lot of times people are worried that they're just going to be hungry, and they fear that. So you want to give them the tools to have enough food and not feel hungry. It does not have to be expensive. And, we definitely see improvements when people aren't 100% compliant. Of course, we want them to be as compliant as possible for those 3 weeks because they get the most information. But they're going to still get a lot of information, even if they kind of cheat here and there, even though you don't want them to. For some patients, especially your celiac patients, they do need to be careful with cross-contamination, and that's critical. They will always ask about coffee, and Can we make an exception for some patients? And you may make an exception for a patient or two if they will not do it if they can't have a cup of coffee in the morning. What about tea? Herbal teas are great and a great thing that you can incorporate into their day. You really want to avoid those added sweeteners and especially those artificial sweeteners. We definitely are avoiding alcohol during the comprehensive elimination diet. And it's a great time for people to kind of get a sense of how much that was impacting them. Definitely avoiding the soft drinks, and thinking with them about what they can do, what they could add. How do they, if they have been eating a lot of dairy, how can they make substitutes to that? What kind of, there's so many great options now for, non-dairy milks and things, but some people need that instruction on what they can do to be successful. And many times you're making a deal with them. You're working with them to determine where are they and where are they within their healing process, and what are they willing to do. And I think that's really important. This is where, in our practice, our nutritionist, I might say, do a comprehensive elimination diet. And then my nutritionist will come back to me and say, they're not really ready yet. Let's really do a 1 food or 2 food elimination because they're not yet there to do that comprehensive. I'm really working to motivate my patient, right? I really want to motivate them to see the benefits of a comprehensive elimination diet. You really got to talk to them about their concerns. Sometimes they come in and they say, well, I tried that before, or I don't know what I'm going to eat. Think about their emotions, discuss with them their concerns around this. Are they afraid that there's not going to be enough food? What are their barriers? Really talk to them about what kind of tools and support they're going to get. Motivate them with the science behind this. Remind them that we want to really focus on this 3 to 4 week period of time and share some success stories with them, right? So, but for example, like I had a 17-year-old boy the other day who was really struggling with acne. And so, of course, you might think, oh, maybe he should do a comprehensive elimination diet. But also he was a 17-year-old boy with a huge caloric need, right? He's an athlete, he had a large caloric need. And he wasn't really ready for a comprehensive elimination diet. So we talked about it. And so what I really focused on is let's do a dairy-free and lower your sugar intake. And, that was really very powerful. And he saw great improvement in his acne. So it's really important that you have that good conversation with your patient, get to know your patient, get to know whether this comprehensive elimination diet is right for them, right? Okay, so, there's really focus with them on the foods to include, foods to exclude, how do they make their kitchen successful? What are those hidden sources of allergens and substitutes? Be a little careful with strenuous exercise. Especially at the beginning, make sure that they are, they can definitely exercise, but, if they're going to be training for and doing a marathon soon, this may not be the time to do a comprehensive elimination diet. Talk about potential reactions and, think about how you can support them with any nutritional or medical food if needed. Remember your screening for that underweight patient, for your children, being very careful with women around pregnancy and lactation, and of course, those patients with eating disorders, and remembering that we don't want to be feeding into that at all. Great handout on hidden foods. And, just to highlight a few of them, milk gets hidden in a lot of different foods out there. You might say casein on the label or lactose. So it's important that people really look at the label, both the what the food includes, as well as the full label to look for any of these components. Eggs as well, really hidden in foods. Corn. I had a patient. She had a mixed connective tissue disorder, and we found out that she had an IgE reaction to corn. And so when she removed corn, she felt so much better. But what she noticed was when she traveled, she didn't feel as good. And we realized that it was really hard for her to remain corn-free with travel because there's so much hidden corn in foods out there that it was a challenge with traveling. So she had to really simplify her nutritional intake with travel. But here are some good substitutes again, and of course, healthy substitutes that we want to highlight for our patients, all within this comprehensive guide. But remember, this takes some time to teach our patients, right? We need to have that space in our practice. We need to have the time in our practice. We need to either have some of these comprehensive guides printed out or available to share digitally. It can take 30 to 45 minutes to really review with your patient how to do a comprehensive elimination diet. And they need follow-up in a week to 10 days. And so, who's going to do that in your practice? Are you going to do that, or do you need to hire somebody to help you? Oh, additives in foods, important to remember. With my son, I always remember this. So he was this was before I was trained in functional medicine. And so he was breastfed, and he was on a liquid vitamin Polyvisol, which many infants are on, and because he was breastfed to get his vitamin D. And then when he started to be able to chew a vitamin, his doctor switched him to a chewable vitamin, and I really didn't even think much about it. But it was at that point, I think he was like 2 to 3, he started to get this rash all the time. He had a rash on his chest or his back. And it took me a while to figure it out, but it was the food coloring in this prescription chewable vitamin that we switched him to. And that was causing this rash. So really pay attention to food additives and coloring. They sneak in there, even when, I'm a nutritionist, but it just sneaks in there sometimes. Remember about potential nutritional deficiencies, especially with your patients who are not eating a whole foods healthy diet. When they remove some of these foods, they can get some gaps. So, we know there's so many other sources of calcium, not just milk and dairy products. But for patients who aren't eating a whole foods diet, they may become deficient. Or eggs, for example, are really nutrient-rich food. So depending on your patient's diet, you have to be a little more careful. IFM has this great handout again on calcium-rich foods. And remember that broccoli, tofu, sardines, almonds, great sources of calcium. It's kind of an overwhelming thing to talk about. And if you've never tried this yourself, I want to really excite you to say, okay, I'm going to try this on myself before, so I know what to expect and how to respond to my patients when they're struggling. So as part of AFMCP, you have the ability and the option to do this elimination diet challenge, and you're going to be doing it with your peers. So join up, in your course material, you're going to see the option to join the elimination diet challenge. And in addition, there's support there's an AFMCP online elimination diet community with support. And really, there's a lot there that you can engage with and learn from. It's a great thing to try if you've never tried it yourself. You're going to figure out for you, what's causing your symptoms. Okay, what if? What if your patient doesn't feel good? If you've tried this with your patients already, many times patients will have adverse reactions right away. Maybe their diet shifts and they all of a sudden are eating more fiber and they get more bloating. Or maybe they get headaches because they just pulled caffeine out. But a lot of times people react to a comprehensive elimination diet within that 5 to 10 days after they start it. And this is not everybody, but some patients will have symptoms 5 to 10 days after the start of a comprehensive elimination diet. And so it's important that you let them know this. You give them a heads up that they may feel a little worse before they feel better. There's a lot of reasons for these reactions. One is the Herxheimer reaction. The Herxheimer reaction occurs when you remove a food that results in toxins being removed from, eliminated from the body. So these endotoxins, these are toxins from bacteria or yeast in the gut. And when you remove their food source, so let's say you stop eating a certain food that was feeding these bacteria or yeasts, then these endotoxins are released into the body and they need to get eliminated through your detoxification system. And so depending on the amount and how your detoxification system is, that may influence your symptoms. Feelings of Herxheimer reaction, patients may complain of brain fog, fatigue, some digestive shifts, even a low-grade fever or headache or muscle pain or joint stiffness. And you can use activated charcoal. Typically an hour after food, you can give some activated charcoal. You can also give some buffered C and make sure they're having good bowel movements. That's really important. The other reason you can react to foods or the removal of foods 5 to 10 days into a comprehensive elimination diet, it may be because of these immune complexes. So what are these immune complexes? On the left-hand side of your screen, you see this is before somebody goes on an elimination diet. And this is a theory as to why people may be symptomatic those 5 to 10 days into a comprehensive elimination diet. So prior to the elimination diet, you have a bunch of antigens, right? You're eating a lot of foods that are inflammatory for your body. You've got some of these antibodies and you have some immune complexes, so you have some symptoms. But then when you remove the foods that are causing all these antigens, then there's more immune complexes that are formed. And you see that here in the middle of your screen, right? This is when there's more antigen-antibody equivalency. So there's bigger immune complexes which can trigger the innate immune system and cause more inflammation in the body and cause more symptoms. And then over time, the antigens decrease because this person has remained on that elimination diet. And so those immune complexes decrease in size again. And so symptomatology will resolve. And so it's important to let your patients know that for the first week, they may feel a little bit worse. Not everybody, but some people do. And then they start to feel better over time. And some of those symptoms may be all the brain fog and fatigue and, even flu-like symptoms and headaches. These slides here just tell you a little bit more about the immune complexes. So what can you do if somebody's having withdrawal from a food substance? You can use some sodium, potassium bicarbonate that can help alkalize the body. We also see withdrawal when you take kids on the spectrum away, you take gluten and dairy away. If they're having symptoms because of these gluteomorphins and caseomorphins, those components from gluten and dairy that can cross the blood-brain barrier, impact that opioid receptor, have an impact on attention and mood, then sometimes they'll have some withdrawal symptoms when you first remove those foods. It's not just for kids also. Other people can have those symptoms as well. You're really making sure the gut things are moving through, right? So you don't want your patients to be constipated. You want to use magnesium citrate or buffered ascorbic acid to help foods move through. You can use some peppermint capsules to help with gas as well, or chamomile peppermint tea, lots of fiber that can help minimize any symptoms. Make sure your patients are eating regularly and they've got a good protein and fat source at each meal. That will help prevent any hypoglycemia. And, buffered ascorbic acid can help with some of the reactions of decreasing caffeine and sugar as well. We talked about the weight piece, with your patients who are already low weight or they don't need to lose more weight. It's really important that you're really helping them get enough calories, working with a nutritionist, having enough options so they don't lose too much weight. And here's just a summary slide for you. So as I keep alluding to, the assessment phase, the reintroduction phase is so important to help you identify really how this elimination diet has helped your patients. So really reintroduction occurs around 3 to 6 weeks after somebody has started a comprehensive elimination diet. Of course, you may choose to keep your patient on that comprehensive elimination diet longer. And so that's just it. But 3 to 6 weeks is a general time where you're going to start to do some reintroduction. So, you want to assess your patient at 3 to 6 weeks and see, is this time to do some reintroduction of foods? And maybe not all the foods, but maybe some of the foods that you want to relax their diet with, if that's appropriate. This is a really great handout in the toolkit. It reminds us that you should only reintroduce one food at a time. When you reintroduce that food, you want them to eat that food twice, a full serving twice in that day, and then wait for the next 72 hours to look for any symptoms that may result. And those symptoms may be within the gut, but they may also be in the joints. They may be fatigue. They may be headache. Remember, if your patient has celiac disease, you are not reintroducing gluten. And there may be foods that you're not going to choose to ever reintroduce, and you don't have to. But if you're wondering if this food is causing symptoms, this is how you do the reintroduction. Here's some common reactions that happen when you reintroduce a food and to food sensitivities. So headaches, more sugar cravings, eczema, rashes, muscle and joint pain, digestive complaints, sinus congestion, runny nose, mood swings, fatigue, depression, irritability, problems with sleep and concentration, all are possible to be seen. And remember, we just want to highlight how important it is to, with your patients that have IgE allergies, they are not doing a reintroduction outside of any close supervision. This is a really good a diagram of how reintroduction occurs, reminding us that you test one food at a time. When you eat that food, let's say you're doing gluten, though that's not the food I typically reintroduce first. So I'm going to say, let's do eggs. You have a full egg twice in that first day, and then you watch for the next 3 days. If there's any reactions during that time, you pull that food back out again and maybe wait another 3 months before you try to reintroduce it again, if you're even going to try. If there's no reaction after 3 days, then you can move on down the line and try another reintroduction of a food. You want to have a full serving size, and this handout shows you what our full serving size is. So an average portion size for egg would be 2 eggs. So you'd want to have, in my explanation before, you'd want to have 2 eggs at lunch maybe and 2 eggs at dinner, and then watch that person for the rest of those 72 hours without reintroducing anything else. So what's really important is you only want to challenge one food at a time. So for example, you wouldn't want to do an omelet that had egg and cheese in it, right? That makes sense, because you wouldn't know which food is causing a reaction. You don't want to do pizza, you do just pasta, right? And you want to give at least 48-hour minimum of watching them for symptoms, but we usually say 72 hours or 3 days. And if you're still having symptoms, don't reintroduce another food, because then you won't know what food's causing what symptom. And keep a really careful food diary. This is critical. And that handout that I was showing you before that IFM has put together is a really good tool that you can give to your patients so they can keep record of each food and their symptoms and how they feel. Because sometimes if you don't do it methodically, and I've got to tell you, this is the thing I see the most, is that patients do comprehensive elimination diets, and then they just went away on vacation and forgot the whole thing. And then they never figured out what food was causing what symptom. That's so important. That's what's giving you all of that information, right? So you want to make sure that they are prepped ahead of time to know that the most important time is that reintroduction phase. And that can take some time to reintroduce one food at a time. So you really want to have them ready to go beforehand so that they know how to do the reintroduction and that they don't just go away on vacation and start eating everything and then be like, well, I don't know, I think I felt better, but I don't really know what from. That's what we see all the time. So it's really important that they do it in a very methodical way. That's going to give them all the information. So I wanted to end with a case because, sometimes people come to see you, and like with this patient of mine, she had a lot going on. She was a 62-year-old woman with pain and fatigue. And sometimes when people come in with a lot of medical history, and I'm going to show you her timeline in a second, it's overwhelming. You don't even know where to start. And so I want to encourage you to start with that comprehensive elimination diet because it can be so powerful. So she had food allergies her whole life. She actually had an appendectomy at a young age, but then it was realized that she had Meckel's diverticulum, and so had multiple surgeries over her lifetime because of this, had further bowel obstructions leading to more surgeries. At the age of 13, she had her first urinary tract infection. And over time, after having multiple urinary tract infections, they found that she had floating kidneys and kinked ureters. So she was predisposed to these urinary tract infections and had them multiple times. So many so that at the age of 39, she started to have symptoms of interstitial cystitis. And it was so painful for her that she went on to have surgery to divert her urine from her bladder. So she had an Indiana pouch done to divert the urine from going into her bladder, and then had revisions of this over the years, and an ileal loop, to make an artificial bladder in her intestines, and just then multiple infections from, as you can imagine, all of these surgeries and a lot of body pain. So came to see me on a lot of pain medications, hydrocodone, and a long history of antibiotics. And her complaint was pain and fatigue. And so you're like, oh my goodness, where do I start, right? Where do I start with somebody with such a real detailed, long history? How can I help this person feel better? Do I give them more pain meds? No. So where do you go, right? And so let's think about that food first approach here. So within the ABCDs of nutrition assessment, which we're going to delve into later on today and tomorrow, but this is just to give you a taste. We're going to think about her nutrition evaluation. So the ABCDs include her anthropometrics, her biomarkers, her clinical indicators, and her diet and lifestyle assessment. So I just organized her information in this way. For anthropometrics, we see that she's overweight. She has a BMI of 31. Her waist to hip ratio is too high. It's 0.91. And remember, for women, you want to be less than 0.8. Her blood pressure is a little high. She's definitely over fat. Her BIA was high as well. I'm going to show you her biomarkers in a second. On clinical exam, we saw some ridges on her nails. Her nails were brittle, so I'm thinking about malabsorption, malnutrition. She definitely had some visceral adiposity. She had multiple scars on her abdomen from all of these surgeries. She had some silver amalgams in her mouth, and her pale conjunctiva, and maybe making me wonder about her iron levels. So let's look at her D, or her diet and lifestyle assessment. So, what we saw on her diet and lifestyle assessment, she was trying to be healthy, right? But what you'll see here is that there's a lot of gluten and sugar that crept into her diet, even though she was trying to be really healthy, right? So she had some brown rice cereal for breakfast with agave and coconut milk. Agave was really big at that time. So cup of coffee. She had whole wheat bread at lunch with leftover steak and an Arizona iced tea. Some more honey in her green tea and some chocolate. She snacked on crackers and cheese, and then at dinner had some chocolate cake with her vegetables and rice, and some more crackers and cheese after dinner. What you can see here is her overall phytonutrient intake was low. The amount of all those colorful fruits and vegetables was low. And as I mentioned, she's got a lot of gluten and sugar in her diet, really leading to inflammation and this metabolic syndrome. So when I started to plot her on her matrix, we can put in the antecedents, her long history of food allergies and multiple surgeries, but then triggering events may be more antibiotics and infections and surgeries, as well as mediators. Her sleep was poor because she had restless leg and a lot of pain. She wasn't exercising because of her pain. She had a lot of stress with this illness. And her interactions with others was also limited because of the amount of pain and fatigue she had. So now I'm going to organize some of her biomarkers in the PFC MVP organizational pattern. So your PFC are your macronutrients, your protein, fats, and carbohydrates, and the MVP are your micronutrients, the minerals, vitamins, and phytonutrients. So her biomarkers, right? In general, her protein, her P was okay. Most things looked pretty normal. For fats, she did not have enough omega-3 fats. Her omega-6 to omega-3 ratio was high, and she actually had some trans fats as well. Her carbohydrates, some things that stood out, she definitely has insulin resistance, metabolic syndrome. She's got a high fasting insulin, high blood glucose, high hemoglobin A1C, high triglycerides, and some mild ALT, AST elevation consistent with fatty liver, probably, which it was. For minerals, we see low iron, that kind of was consistent with the pale conjunctiva. And her red blood cell magnesium was also low. Interesting with the restless leg, both the magnesium and iron, right? For vitamins, her vitamin D is a little on the low side. Her methylmalonic acid, which gives us an indication of B12 levels, was normal, but a little high for me. I like it under 200, so it's a little low in B12 as well. And for phytonutrients, we could see I did an organic acid panel, and she was low beta carotene and high lipid peroxides. And she had high C-reactive protein. No wonder she wasn't feeling good and was in a lot of pain. This was her MSQ that she filled out. Interestingly, it was 59. Other people with this amount of pain and fatigue would have been in the 150s probably. She was stoic. She did have some history of vaginal yeast. I talked to you about the muscle cramps and the restless leg. She was low in thyroid and had some fatty liver. We did find some dysbiosis on stool testing and multiple food sensitivities. Interestingly, her IgE food allergies were completely negative, but multiple foods on the IgG sensitivity tests. And we did do a test. We did a lactulose mannitol test for food for increased intestinal permeability that I'll show you in a second. And her saliva cortisol levels were low, consistent with some HPA axis dysfunction. And this was her lactulose mannitol test, and you can see that she's got a borderline elevation here. For this test, I don't always do this test. I'm often doing like a antibody testing for intestinal permeability, antibodies against zonulin. But for this test, it was, I would consider this positive. When I see it this high, or definitely in the red, you would call that increased intestinal permeability. So if I went on to fill out her matrix, we could put under nutrition, some deficiencies in magnesium and iron. We definitely had some dysbiosis that we needed to deal with, and signs of malnutrition and malabsorption. Under defense and repair, a lot of inflammation, dysbiosis, visceral fat, and food sensitivities. She was on a lot of pain medication impacting her detoxification system. And she definitely had sign of metabolic syndrome, hypothyroidism, and adrenal issues. And really, in this mental, emotional, spiritual, loss of hope. She did not even know where to go or what to do next. She had a medical background on herself. She knew a lot about stuff, and it really didn't know if there was anything more she could do to help herself. And so I said, well, have you ever tried a comprehensive elimination diet, right? Let's just try it. Let's see how you feel. And so I said, let's do it. Let's pull away. Let's shift around your diet. Because of her metabolic syndrome, we also pulled away more carbohydrates. So it was kind of a combination with the comprehensive elimination diet and cardiometabolic food plan. And we really focused on getting her much more phytonutrients and increasing her vegetable intake. And within a month, she lost 10 pounds. She was like, this is amazing. I've been trying to lose weight all this time. And, I explained to her, you removed some foods that were causing inflammation for your body. She was able to decrease her pain medication by 2/3 in that first month. Amazing. She added in iron and magnesium, And at 3 months, look at that MSQ down to 10. Her fasting insulin, great improvement to 7. Her liver functions normalized. Her blood sugar came down. Her iron improved. Her red blood cell magnesium improved. And most importantly, she was able to get really weaned down on the pain medication. Her sleep was better. Her restless leg decreased. And she wasn't getting these chronic infections that needed antibiotics, all with a comprehensive elimination diet. It's so powerful. So especially with those patients that are, overwhelming to you, really think about, okay, let's start with this comprehensive elimination diet. Let's see how much that can help you. Remember, it is evidence-based. There's a lot of evidence out there, and looking through the addendum on this deck, you can find some if you want to look through that yourself. Remember that a nutrition professional can help you and your patients be successful. So they need to have a lot of support. They need check-in at 1 to 2 weeks and 3 to 4 weeks to increase compliance. And you don't want them to just stop doing the comprehensive elimination diet. You need them to reintroduce the foods methodically. Comprehensive elimination diet is free and it's effective. So, Monday morning, get those 50 copies of the Comprehensive Elimination Diet MSQ Symptom Tracker ready to go, whether you're doing it with paper or electronically. Always remember to look beyond just the gut. Some people have the joint pain when they reintroduce a food, or the headache or fatigue. It might be a vague, it might not be a strong reaction. So you have to think about all that. Encourage them for those first 21 days to be as compliant as possible. But then also remember that 80-20 rule. You want to reintroduce as many healthy foods as possible, and encourage them to have a variety in their diet, to have a varied diet rich in phytonutrients. And this is a great handout for you to keep aside and say, okay, when am I going to do that comprehensive elimination diet? Just to remind you, okay, these are the patients I need to do it with. So thank you so much for being with me today. And it was great to discuss the power of food and the comprehensive elimination diet with you.